look, I'm getting these really funny heartbeats. Oh, that's anxiety.
Other aspects of lifestyle which may be relevant.
Be patient with yourself and just build up gradually.
So I just needed to have them work with me.
There's a whole bunch of cardiomyopathies.
Benefits of doing genetic testing.
Take their own heart monitor. There's better types of fat.
Try and find a cure for inherited heart muscle diseases.
And I'm going to talk about women's health and cardiomyopathy and how they are intertwined. Now, it would be wrong to talk about differences in men and women without making very clear that women are complicated and very different. I'm going to spend the next 30 minutes, maybe 35, elaborating on that. These are the objectives of the talk that I was given, which it's quite a lot to talk about, so I won't spend too long. I know that you've had lots of talks about the various specific cardiomyopathies already, so I'm just going to talk about very focused on gender differences in the various different cardiomyopathy types. So hypertrophic cardiomyopathy, women tend to present later than men, and they tend to be more symptomatic by the time they do present. They are more likely to present with outflow tract obstruction than their male counterparts. The inheritance pattern is autosomal dominant. You know all of that. Men and women equally affected. The only reason I'm mentioning this is because Anderson-Fabry disease, which can look like hypertrophic cardiomyopathy, is not autosomal dominant. It's X-linked, which means that men are more affected because they only have one X chromosome, whereas women have two X chromosomes, which is typically only one of them affected, and they are carrier they are carrier, therefore, of the disease. But we now know that 70% of women with this, who carry this gene, have got symptoms also, or signs of the disease. Arrhythmogenic cardiomyopathy tends to affect men more. Apparently, they are more likely to present with significant rhythm abnormalities, and it seems to be linked to exercise. So the more exercise you do, the more severe you may be affected. Disease progression, however, is very similar in men and women. Dilated cardiomyopathy is a difficult one because it's such a mixed bag. Only about a third of them are inherited, and the male to female ratio is about 3:1 for this inherited and myocarditis-related type of dilated cardiomyopathy. It's interesting for us with our obstetric hats on because dilated cardiomyopathy usually means that the pump function of the heart is reduced. And the ejection fraction, which is the measure of pump function that we typically use, helps us predict what a pregnancy might look like for somebody with dilated cardiomyopathy. There is a mouse model of myocarditis and dilated cardiomyopathy, and the investigators found that estrogen seems to have a protective effect on the heart muscle. This is the female sex hormone, whereas testosterone, the male sex hormone, can accelerate disease progression in mice. There's very little known about humans in that respect. I'm not going to dwell on restrictive cardiomyopathy. It's extremely rare, and it also has many, many different etiologies, and the inheritance pattern there, if it is inherited, very much depends on what the underlying pathology is there. Broken heart syndrome, or Takotsubo, or stress cardiomyopathy, some of you may have heard about this morning. I think this is well placed in this talk because it almost exclusively affects women, and interestingly enough, mostly women who are past the menopause. It's a cardiomyopathy that is triggered by extreme stress, which can be physical, such as a trauma or an injury, but also emotional. Usually people make a full recovery. They don't always, but usually they do. And the very few men who develop this disease tend to do much worse than the women, as you can see by the 30-day mortality, which is more than double for men compared to women. 1 in 10 people who have this cardiomyopathy will get it again. And most frequently, the recurrence happens after around 4 to 5 years, but recurrences have been reported as late as 10 years down the line from the index event. Those of you who haven't heard about Takotsubo cardiomyopathy very much, the reason it's called that, it's because the heart, the shape of the heart, resembles that of a Japanese octopus trap, which is here in the middle. And you can see that when the contrast is injected into the left ventricle, it looks exactly the same. The narrow neck and the tip of the heart balloons out like this octopus trap where the octopus crawls in, makes itself at home and then can't get out. The best way to diagnose this and make a firm diagnosis of this particular cardiomyopathy is with an MRI scan, because it gives us the wall motion abnormality, and you will now recognize that the neck or the base of the heart is contracting very well normally, and the apex or the tip of the heart doesn't contribute to contraction at all, and it assumes that same octopus trap shape. MRI gives us the ability to characterize the heart muscle tissue, and with this T1 and T2 map, we can say there is interstitial expansion, which you can see by the different color code here. This is the T1 map, and the T2 map will tell us about why there is interstitial expansion, and here it is edema, it's water. This particular type of scan is sensitive to water, so we know that the swelling is due to edema, water sitting in the heart muscle, stopping it from working properly. The other cardiomyopathy that you men are going to miss out on is peripartum cardiomyopathy. It's a pregnancy-associated cardiomyopathy, and that means that it occurs typically, or by definition, in the last month before the baby is born, up until 5 months after delivery, give or take. We've had people who had it 6 months after delivery. It looks and behaves like a dilated cardiomyopathy, and it can be very difficult to diagnose, particularly if it affects women who are still pregnant, because come the end of the 3rd trimester, you will feel exhausted, lethargic, tired. You may feel breathless and exercise intolerant, and those are the symptoms of a typical late stage pregnancy, but also the symptoms of peripartum cardiomyopathy. And I know Rebecca will talk about this after I've finished, why this can so easily be missed. The geographical distribution is interesting. If you live in the Western world, the risk of developing peripartum cardiomyopathy is 1 in 1,000 to 1 in 4,000, depending on which study you look at. If, however, you happen to live in Haiti, your risk would be 1 in 300, and if you are Nigerian, your risk would be 1 in 100 of developing peripartum cardiomyopathy. There's very, very much a geographic but also familial clustering, and the thought, we're not entirely sure what's causing it, but there is some evidence to suggest that there is a genetic predisposition. In cohorts of women with peripartum cardiomyopathy, they found mutations in the titin gene. But then there's also influence of pregnancy and the pregnancy-related hormones and the hemodynamic changes that take place during pregnancy that will, in part, be responsible for this. Apparently, in Haiti, there's very little zinc in people's diet, and in Nigeria, people are lacking selenium. Whether that's causative, we don't know. But the risk factors are advanced maternal age, any hypertensive disorder of pregnancy, such as preeclampsia. If you're pregnant with more than 1 baby at the same time, your risk is higher. 50 to 80% of women with this condition recover fully. Some recover partially, and some don't recover at all. And the ejection fraction, our measure of pump function at the time of diagnosis, is a very good predictor of recovery. So the lower the ejection fraction at the time of presentation, the less likely the woman's heart is to recover. We also know that women of black ancestry are less likely to make a full recovery than those of non-black ethnicities. When it comes to treatment, we treat them like a dilated cardiomyopathy. It looks the same, we treat it the same way. You may have read about bromocriptine. At Barts, we don't routinely use it. It's a medication that inhibits prolactin. Prolactin is the hormone that's necessary to make breast milk. And it's thought that some of the precursors of this hormone in the body play a role in the development of peripartum cardiomyopathy, but the evidence is mostly in mice, and there are some very small studies in humans with all kinds of problems, so we don't routinely use it, although you could argue that if you have a woman who is extremely sick, she's not going to want to breastfeed anyway, and you've got nothing to lose, so you might decide to give it, even if that means she's not going to make breast milk. The risk of recurrence in the subsequent pregnancy is somewhere between 20 and 50%. And again, if the heart makes a full recovery, the risk of recurrence is lower. So we've talked a lot about what happens if. So what about pregnancy then? What happens in pregnancy to the heart? Quite a lot, actually. So for a cardiologist, pregnancy is like 9 months on the treadmill. A healthy heart has no problem sustaining that. But if you have heart problems, you may find it difficult to increase your cardiac output over the course of the pregnancy, which needs to rise by about 30 to 50% over time. And that is achieved. So the cardiac output is the amount of blood that's pumped around by the heart every minute. It is the product of heart rate and stroke volume. How many times does the heart beat every minute, and how much blood is pumped out with every heartbeat? And that's the stroke volume. All of those go up, and most notably and most steeply in the first trimester. So the changes are happening often before the woman even knows she's pregnant. The aggravating factor is that the circulating blood volume needs to increase to maintain these changes. And it mostly increases by retaining water rather than making lots more red blood cells. So there is a dilution effect. So pregnant women have a lower hemoglobin red blood cell level than the same woman in the non-pregnant state, and that can cause breathlessness in itself. So again, you can see where this is going. Breathlessness, often a marker of heart disease, can happen in a normal pregnancy. The guidelines, this is from the European guidelines, but the guidelines for managing heart disease in pregnancy all over the world stipulate that every woman with a cardiovascular disease should have preconception counselling. Not to scare the living daylights out of them, but to empower them to make informed decisions about whether or not, first of all, what the risks are, and secondly, whether they're prepared and those around them are prepared to take those risks. And interestingly, there are a great many women with heart disease who can go through a pregnancy without too much trouble and without too much risk. So how do we risk assess? We use the modified WHO guidelines, and you don't need to read all of this, but you can see here the bit that I've highlighted is the risk percentage, or the percentage of maternal events. How likely are you, as the mother, to run into trouble during the pregnancy? And you can see that if you are in class 1 or 2, the risk is really quite low. If, however, you are in class 4, your risk is almost prohibitively high. And most of us who do preconception counselling would advise against a pregnancy. Now, we might advise against pregnancy, but then there are a great many reasons why women may choose to take that risk anyway. These may be personal reasons, religious reasons, cultural reasons. So we don't judge. We're just giving the information for you to make the decision yourselves with your families and support networks. So how do these guidelines apply to cardiomyopathy? Class 2 and 3, limited risk. You have, if your left ventricle or the right ventricle is mildly impaired, if you have uncomplicated hypertrophic cardiomyopathy, and by uncomplicated I mean not with significant LV outflow tract obstruction. If, however, you have severe outflow tract obstruction or severe impairment of the left or right ventricle, if you have pulmonary hypertension, if you have peripartum cardiomyopathy that hasn't fully recovered, your risk is somewhere of running into problems during the pregnancy would be somewhere between 40 and 100%. So when we do see women for preconception counselling, the questions we need to consider are, is the woman going to be able to increase her cardiac output to maintain that pregnancy? Is she at risk of developing heart rhythm disorders? And pregnancy itself is arrhythmogenic. Some perfectly healthy women develop rhythm abnormalities during pregnancy, even though they've never had anything before. So if you have a predisposition to rhythm abnormalities, you are at risk of developing them during pregnancy. Pregnancy makes the blood sticky. And if your heart isn't pumping very well, the blood is stagnant in there and can form clot, more so than in the non-pregnant state. So sometimes we need to consider thinning the blood of the woman. Are there any changes that need to be made to your medication? Some medications that are routinely prescribed for women with, or for patients with cardiomyopathy are not safe to be given in pregnancy because they're teratogenic, and I'll come to that in a minute. Is the condition likely to worsen because of the pregnancy, or is it that we're taking away some medication that stabilizes the condition to make it safe for the baby, that it's making it less safe for the mother? Are you going to be able to come to clinic all the time? And that may not be the case if you're traveling a lot, if you're living far away from the center that looks after that provides your antenatal care. You may not be able to come every month or so. And finally, who is there if you are not well? Who's there to look after you? Who's there to look after your baby should you run into serious trouble? And here, I would like to illustrate, use these two hearts to illustrate why some women might not be able to increase their stroke volume. We've got two very different hearts. This one is a big heart. It's dilated, it's weak, it's not pumping very well, and you can imagine that this woman with dilated cardiomyopathy is going to struggle to increase the cardiac output because the heart muscle is weak. This woman, on the other hand, has hypertrophic cardiomyopathy. She has a very vigorous contraction here and a very thick heart muscle. That means the cavity is very, very small, and the heart cannot stretch very much because there's so much muscle around it. So for very different reasons, this woman is also going to struggle to increase her cardiac output during pregnancy. So what about pregnancy then? So who's there? The pregnancy heart team is the multidisciplinary team that should be looking after you in your pregnancy. And at the center should always be you, the patients, and you, the family and friends. This is the minimum of a pregnancy heart team that you should have. You need a cardiac-minded obstetrician and a cardiologist with an obstetric hat on. You need a midwife, of course. And you need an anaesthetist who will be looking after the hemodynamic side of things and the pain control during birth. We may co-opt other members to the team. So the GP, for example. If we think that you're not going to be able to go to term with your pregnancy, sometimes during the later parts of the pregnancy, there's another hike in cardiac output. So we may choose to deliver earlier. And we usually try to get the woman to about 34 weeks gestation, because the outcome for a baby born after or at 30 weeks gestation is almost the same as that of a baby born at term. So if we can get you to 34 weeks, we're happy. But then we need a neonatologist, for example. If there is a need for intensive care, we need an intensivist. We may need a hematologist who knows all about thinning the blood if necessary. And I've brought two examples of pregnant patients, two patient stories that illustrate this. The first story is that of an older mother, 35. She already had 2 children. She was living with obesity, and she had slightly obscure obstetric history. She told us that during her previous pregnancy, which was 6 years prior, she was admitted to the intensive care unit and was told she had a big heart. Now, to me, that would have prompted some further investigation, but it didn't. So no diagnosis was ever made, and then she met a new man and decided that they would like a child together. So she got pregnant and was admitted in florid heart failure on death's door with an ejection fraction of only 20% to another hospital. She was then referred to us for further care, and we had her and her partner had a long discussion about what might be, and we offered her a termination of pregnancy on medical grounds because we thought her life was at risk because of this pregnancy. She said, "Thank you, but no thank you. I'm very keen to have this baby," and we said, "Okay, let's try." She remained remarkably well on a bit of beta blocker, a little bit of a diuretic, and she was able to complete most of her pregnancy as an outpatient. She came to clinic every 4 weeks or so, and we kept a very close eye on her left ventricular function. Now, that isn't always easy, and this is her. You can see why. You don't have to be a cardiologist or a physiologist to see that you don't see very much. I took these. I'm not proud of them, but it was the best I could get. She was a very large lady, and she was pregnant. And at 20 weeks, I could just about see her heart. 2 months later, as the pregnant womb pushes up the diaphragm, the heart disappears to the left into where the axilla is, and you lose all echo windows. So I couldn't say what that heart is like. And thankfully, we treat patients, not numbers. So we delivered her. We managed to get her to 34 weeks as planned. We had talked to her about the fact that this should probably be her last pregnancy. So in advance, she agreed to having a tubal ligation. During the time of cesarean section, she had an elective cesarean section with lots of monitoring on board, delivered a healthy baby, and we continued with the beta blocker. Once the baby was out, we could start her on an ACE inhibitor, and she did incredibly well. A year down the line, her ejection fraction had come up from 20 to 52%, and at 2 years' time, when I saw her in clinic, it was normal. It could have been peripartum cardiomyopathy. We'll never find out. This story is a different one. I met this young lady when she was 17. She was an asylum seeker who arrived in the back of a lorry from Vietnam. She was referred by her GP because she had palpitations, shortness of breath, and chest pain as she was running for the bus. She came to clinic with her social worker, and we had an interpreter and managed to tease out that her father had passed away suddenly when she was very young. That's all she could tell us. On examination, she had a murmur, and her ECG looked very abnormal, and the echocardiogram then confirmed that she had hypertrophic cardiomyopathy. I referred her to the cardiomyopathy clinic, who looked after her very well, and she got referred back to me because she expressed a wish to have a baby. I did some preconception counselling with her and asked her to make contact as soon as she was pregnant, which she did. This is her in the pregnant state. And those of you who are used to looking at hypertrophic cardiomyopathy will recognise this very thick heart muscle here, a tiny cavity, and this colour flow Doppler tells us about whether there's turbulent blood flow. So she had quite a lot of outflow tract obstruction and also obstruction in the mid-cavity. We knew all of this, so we could be prepared. She was able to deliver at term. She had a normal vaginal delivery. Urban myth number 1, if you have a heart problem, you need a cesarean section. Rubbish. She delivered a healthy baby. We talked about contraception, and she was able to go back to her regular follow-up in the cardiomyopathy clinic. And I hear she's considering another pregnancy. So these are 2 successful examples. But it does sometimes go wrong. And where does it go wrong? I bring up this graph again in a slightly modified version. But you can see here, and I said this before, the hemodynamic changes happen very early on in the first trimester. So if the woman is going to fall off her perch, that typically happens at the end of the first or at the beginning of the second trimester. And then there's an increase of cardiac workload towards the end of the pregnancy, and that's why we deliver at 34 weeks if we need to avoid this peak. And then I'd like to draw your attention to the red bar, which is delivery. And you can see that from there, everything, absolutely everything, changes very, very rapidly. And you can imagine that someone whose hemodynamic situation is a little bit unstable introducing this kind of instability is difficult sometimes. So that's when things can go wrong, and that's when we need to pay extra close attention. And in the case of the last lady I presented, this is what my colleague did for her. This was given to me by Adrian England, one of my anaesthetic colleagues, who very, very closely kept an eye on cardiac output, blood pressure, stroke volume. He documented in minute detail when he gave what. He marked when she delivered and when she vomited. You don't need to spend much time looking at that, just to appreciate how much monitoring there is. And if we just look at this blood pressure chart, this is hers, and this is when she delivers. But you can see this is systolic blood pressure, and you can see it goes up to somewhere on 140 systolic, and then it drops, and then it goes up again, and then it drops again. And once she's delivered, we're looking at somewhere 70 millimeters of mercury. So this is despite all the monitoring and all the, keeping a very close eye. So why is time of delivery so critical? The cardiac workload increases during the pregnancy. It culminates in labor. The delivery of the baby causes a very abrupt change in the circulatory conditions. With a normal vaginal delivery, the average blood loss is about 300 mils. With a caesarean section, all going well, we're looking at a blood loss of about 800 mils, if everything goes well. But heaven forbid if there is a hemorrhage. And then we're going from a very, very full circulation to a very, very empty circulation as the woman is bleeding. So this is mayhem. This is what we're trying to avoid at all cost. But anticipating these changes and with close monitoring, we can make this very unstable time for a woman in a woman's journey through pregnancy an awful lot safer. Quick run through medicines that many of you will recognize. Beta blockers are perfectly safe. That's everything that ends in ol. Except for atenolol, we don't like that. It produces small babies. Aspirin is perfectly safe. Furosemide, a diuretic, is perfectly safe. Flecainide, if you're on that for your heart rhythm, please continue on it. Low molecular weight heparin, contrary to what the name suggests, is actually quite a large molecule. It's so large that it doesn't pass the placenta, so the baby doesn't see any of it. And warfarin is not safe, but I've put it there because it's safer after the second trimester, or after the first trimester when the baby's organs are fully formed. So what is not safe in pregnancy? Let's continue on the warfarin. Warfarin in the first trimester can cause abnormalities in the baby's organ development, and that's known as warfarin embryopathy. There is some data to suggest that if the dose that you're taking regularly is less than 5 milligrams, the risk of developing warfarin embryopathy is less. But the flip side of the coin is that during pregnancy, the volume of distribution changes, which means that the doses may need to be adjusted in pregnancy. Anything that ends in pril is an ACE inhibitor and is contraindicated because it is teratogenic. Similarly, anything that ends in sartan is also contraindicated both during breastfeeding, during pregnancy and in breastfeeding, whereas the ACE inhibitors are safe. And we have most evidence with enalapril because it's been around for eons and we think it's safe. If you're on Entresto, you can't be on that while you're pregnant or breastfeeding because it contains valsartan, which is an angiotensin receptor blocker, and sacubitril, which is toxic in animal studies. The gliflozins. There's much hype about the gliflozins, but we have no data on them in pregnancy or breastfeeding, so the advice is to avoid. And you can see if we're going to have to take those away, that in itself might be a problem. Spironolactone and eplerenone we don't give during pregnancy because it can affect a male fetus by making them, or feminizing the male fetus, but we think it's safe in breastfeeding because only very tiny amounts are excreted into breast milk. Where does that information come from? For breastfeeding, we haven't really got much other than the BNF, but the BNF, what you read in there, sometimes you have to take with a pinch of salt. They are extremely conservative when it comes to advice about pregnancy. The BNF says that beta blockers must be used with caution, for example. Now, if we can't give beta blockers, we're all doomed. This is much better. This is a website run by Ken Hodson, who is a member of the MacDonald Obstetric Medicine Society. It's the UK Teratology Information Service, and they have a patient website. There's a link on this website to BUMPS, Best Use of Medicines in Pregnancy. So if you're a patient, look for BUMPS. If you're a healthcare professional, they've got information on virtually anything you'd ever wanted to give. Just a few words on pre-implantation genetic testing. If you carry a gene that is known to cause cardiomyopathy, you can have pre-implantation genetic testing, which means the eggs are harvested, there's going to be an in vitro fertilization of those eggs, and the embryos created will then be tested for the presence of this gene, and only the embryo that doesn't carry the gene is then implanted into the womb. Referral usually takes place through the genetic counsellor, and the NHS will pay for this, but only for one child. I think if you want to have another one, you're looking at somewhere around £20,000. It's not cheap. I promised to talk about menopause. So what about cardiomyopathy and menopause? I think the honest truth is there is not an awful lot of information out there. And although 35% of deaths in women around the world are due to cardiovascular disease in women is understudied, under-recognized, it's underdiagnosed, undertreated, and women are underrepresented in clinical trials. Now, cardiomyopathy and menopause can mimic each other. Lethargy, exercise intolerance, just feeling generally lethargic can all be symptoms of menopause and cardiomyopathy. Now, hormones may play a role, of course, and we know from studies that myocarditis occurs predominantly in young men and in postmenopausal women, so there might be a hint there. And if we look at that study of mice, maybe it is that after menopause, women lose that protective effect of estrogen over the heart muscle, The fact that stress cardiomyopathy, Takotsubo cardiomyopathy, mostly affects women after the menopause would support that. But watch the space. There's not an awful lot known about it, but there is a pledge by the WHO and others in other institutions to reduce the burden of cardiovascular disease in women by 2030. So hang in there, watch the space. There may be more known in 5 or 10 years' time. So to conclude, there are sex differences in different types of cardiomyopathy, and that may be because of inheritance patterns, but also disease expression and progression. Pregnancy carries an additional risk in women with cardiomyopathy, but it's not necessarily prohibitive. It's all about being forewarned and forearmed and planning everything from preconception through to pregnancy, through to delivery and postpartum care that can make pregnancy an awful lot safer in women with cardiomyopathy. The effects of menopause are not well studied, and I'd like to leave you with a little bit of cardio pop art before I hand over to Rebecca, who will take on from here and talk about peripartum cardiomyopathy. So there you go.
Thanks very much, Anna. I'm really glad to be here and have the opportunity today to share with you just briefly some of the work that we've been doing to raise awareness of peripartum cardiomyopathy. My name's Rebecca. My interest in peripartum cardiomyopathy stems from my background as a midwife and also as a person living with cardiomyopathy. So peripartum cardiomyopathy, as we've just heard, occurs uniquely in women and specifically as a result of pregnancy. And it continues to be under-recognised, under-diagnosed and under-treated. Because symptoms of PPCM overlap with symptoms commonly experienced in pregnancy, and when women mention them to their clinical team, they're often told, well, you're pregnant, what do you expect? But these symptoms are clues that need to be taken seriously and explored further, as if they aren't, then the disease progresses unabated, the heart function deteriorates, and women present in acute heart failure, which is harder to treat and harder to recover from, as Anna's just mentioned. And the pain and frustration that women feel through not being listened to by their clinical team was a major finding of a focus group that we held last year, where women who were diagnosed with PPCM shared their stories. Their stories all had a common theme of women having their symptoms and concerns dismissed by clinicians, not taken seriously or explored further or investigated early enough. The group was unanimous in agreeing that raising awareness of the condition, not only amongst clinicians, but also amongst the general public, was of critical importance. If more was known about this condition, they wouldn't have suffered so much pain, frustration, and in some cases, lasting trauma. One of the women in our focus group was a young mum called Laura. Laura was diagnosed with PPCM at the end of her pregnancy when she was so ill she required hospital admission. Laura had repeatedly described her concerns about feeling breathless and swollen at her antenatal appointments, but these had been dismissed as normal for pregnancy each time. Her symptoms became increasingly severe and she became extremely unwell. An ambulance was called and she was taken to hospital where these symptoms were finally taken seriously, and after investigations she was told that she had PPCM. She was transferred to a specialist centre for the birth, where a multidisciplinary team looked after her and her baby. But after the birth, her condition became so critical that she was admitted to the intensive care unit. She spent several weeks, months in fact, in hospital, and was later told that she would probably need a heart transplant. Laura and her family were determined to raise awareness of the condition so that other people wouldn't suffer due to delayed diagnosis in the way that Laura had. And so they decided to fundraise. And this poster is a result of that fundraising. As a collaboration between the Royal College of Midwives, the UK Maternal Cardiology Society and Cardiomyopathy UK, the poster highlights the symptoms to look out for during pregnancy and poses the question, could it be PPCM? Earlier this month, we launched this poster at an event hosted by the University of York Health Sciences Department, where Laura's family were present and shared her story. We aim to distribute this poster to maternity units across the UK to be displayed in antenatal waiting areas, in full view of the general public as well as clinicians. Exactly 1 year ago today, Laura sadly died. So it's really poignant that we're here today telling her story and showing the poster that's been created with her family's fundraising efforts. Her family are now even more determined to raise awareness of PPCM. So as well as sharing the poster, I'd like to invite you to take the PPCM pledge, to tell at least one person about PPCM over the next year to help us spread the word. Please come and sign the PPCM pledge poster. It's at booth number 9 in the foyer. It's absolutely vital that we raise awareness of PPCM so that these tragedies stop occurring. Thank you.
Is that on? Brilliant. Thank you, Anna. Thank you, Rebecca. We've got some time for a few questions. I'm going to take the first one off the app, so I don't know whether people have been using this, but we're going to try and do 4 for the price of 1 because there's about 4 questions relating to HRT. So it's probably, if you can maybe just talk a little bit about HRT and other sort of menopause therapy for women with cardiomyopathy, that would be very helpful.
Thank you. I still have this. So the honest truth is that we don't really know. We barely know what HRT does to the cardiovascular system in general. I think there's a timeline here. In the 1980s, they found out that women, postmenopausal women, started developing cardiovascular disease. Now that refers mainly to coronary artery disease and atherosclerosis. But they thought, oh, well, let's just give HRT to every woman in the menopause and see what happens. So they gave HRT freely, like Smarties. And then in the 90s or so, they found that actually that was detrimental. And then in the noughties, there was a... They looked at it in a little bit more, or slightly more differentiated way, whereby they said, okay, well, it seems that if we give HRT to women who are younger and literally just around perimenopause, that will have a beneficial effect. What it does to women with cardiomyopathy, I have no idea. I'm really sorry.
Do we have any questions from the floor? Don't be shy. Come to you.
My question is related to men having more arrhythmias with cardiomyopathy than women. Is that because of the intensity of exercise that they might do, like marathon runners and having scarring in the sinoatrial node, or what? Because you don't want to discourage the exercise, right? So can you elaborate a bit more as to why men might have more arrhythmias than women, please?
When I researched this, that was the exact question I was asking myself, whether it's due to the fact that men may be doing more exercise than women, but then I wondered whether that is actually true. I think Perry may know the answer to this because he's vigorously shaking his head. Do you have anything to say?
That's not the explanation.
But do you have one?
No.
Okay, there you go. If Perry doesn't know, I don't know either. We don't know.
Any other questions? Yeah, well, I'm going to take one from here, and then, yeah, that's fine. So there's a question here. It says, are there groups of people, I guess groups of women as well, that are at greater risk of developing cardiomyopathy or greater risk of becoming seriously ill?
Sorry, let me clarify that. During the time of pregnancy or in...
I think in general.
Sorry, could you repeat the question?
So, are there groups of people at greater risk of developing cardiomyopathy or at greater risk of becoming seriously ill?
I think it depends on the type of cardiomyopathy, really. I think women, in comparison to men, I don't think so. I don't think so, no, unless there is a disease inheritance pattern that favors women, but I can't think of one from the top of my head. It's usually the men who only have one X chromosome, sorry guys, who tend to be more affected. I can't think of any particular group of women who are more at risk than others.
What about women with autoimmune conditions? Things like thyroid or SLE or other autoimmune conditions, would those women potentially be more at risk of things like dilated cardiomyopathy?
Yes. Yes, they are. Many autoimmune conditions go hand in hand with dilated cardiomyopathy types and myocarditis, which sort of is probably related in many ways. So, yeah, and it tends to affect women later in life. But very much the autoimmune conditions, so SLE, those with thyroid antibodies, thyroid toxicosis, for example, can also cause cardiomyopathy. And some of the autoimmune conditions flare during pregnancy, so that's another epigenetic, or not epigenetic, but another confounding factor that makes it more likely for women with immune diseases to develop cardiomyopathy.
Thank you.
Hi. Just wanted to know how common atrial fibrillation is in pregnancy. I had what I thought was an episode of that, recorded it on my Apple Watch, don't know how reliable that is, but mentioned it to the midwife. And I think it's so sad about what happened in regards to, what we've got on the screen, because I was, raised the fact that my dad had that condition and was basically just told, if it happens again, let us know. And I don't know how routine it is to follow up, an episode of that unless it happens consistently. But I just think it's so sad about what happened in this instance, because it must be really difficult to, like you say, because it's so common in pregnancy to have various symptoms that appear as something else. And I guess from the conference today, we're learning just how important it is to advocate for yourself and try and push for things to be investigated. Mm-hmm. So how common is that in pregnancy?
Pregnancy in general can give you any kind of rhythm disturbance, including atrial fibrillation. And sometimes we see women who have their first ever episode of atrial fibrillation during pregnancy. We then typically investigate them with an echocardiogram to see if the heart is structurally and functionally normal, in which case we're less worried about it. But that doesn't mean we're not worried about it, because we typically also do a 24-hour ECG or a Holter to see how much time you actually spend in this abnormal heart rhythm, or even might be monitoring for a longer period of time. And the reason we want to know specifically in pregnancy if you've got atrial fibrillation is because of that state of hypercoagulability, that stickiness of the blood that makes you more likely to develop clot when you are pregnant. Normally, a young healthy woman with a structurally and functionally normal heart, you wouldn't necessarily give blood thinners to, but in pregnancy I always do, because I can't think of anything more catastrophic than a stroke in a young woman. Does that answer the question? It very much depends on who your midwife is. And Rebecca, for example, is leading on midwife education. So if you have an educated midwife with a medical hat on, they might say, okay, I think you better see, or we better look into this, which is what should happen to avoid things like what happened to Laura. But part of the problem is the lack of education generally. I think cardiovascular disease in pregnancy we don't do that very well as a country or even in the world. There is very little awareness of it, and if you know about it, it may be that you know more than the people around you looking after you, which is not ideal, and that's one of the reasons we're here, to raise awareness and make sure that there is education. Part of the problem is that midwives no longer need to have any medical training. I think you can go straight into midwifery without training as a nurse first, and I think that means you can go into midwifery without ever having heard anything about cardiovascular disease or any medical problems in pregnancy, and that creates more problems, because then there's less awareness, but then there's a great deal of education happening.
So an interesting fact is that so there are confidential inquiries into all maternal deaths occurring in pregnancy or the year following pregnancy, and time again, like for about 20 years now, the leading cause of maternal mortality has been cardiovascular disease. So that is the major cause of death in young pregnant women due to pregnancy. And I think because of that, I think the word is getting out to midwives. There's more education, there's more talk about it. We've now got maternal medicine networks which are being set up. They're quite a recent establishment, really, so that each area across the UK has this network of specialist centres where women with these conditions can be referred to. I mean, the issue with peripartum cardiomyopathy is that you don't have a pre-existing known cardiovascular disease. It's something that just occurs in pregnancy in an otherwise normal, healthy person. And so they're not going to be under the care of the maternal medicine network where they're getting all this specialist input. They're just going to be seeing their community midwife in the antenatal clinic. And that's why we're trying to raise awareness amongst midwives, because they're the first person, you know, that a pregnant woman is going to come into contact with when she finds herself pregnant and see the most often throughout that journey. You know, and the sad thing is that, you know, through this focus group, and you hear time and time again that women, you know, they speak about these symptoms and the healthcare professionals are telling them that it's normal, you know, that it's because they're pregnant. So that's why we're just, you know, trying to raise awareness. If you don't know about a condition, you know, you can't consider it, can you? And you don't know that someone needs to be referred. You don't, you know, often it's just a case of asking a few more questions, digging a bit deeper, you know, finding out the extent to which these symptoms are having an impact on just daily activities. So rather than just sort of routinely just dismissing and just focusing on pregnancy symptoms, and this happens, you know, when you are pregnant, that healthcare professionals and even just the general public, they can't see past the fact that you're pregnant. You know, that overshadows everything, and people become blindsided by the fact that you're pregnant, and they miss other diseases because you're so focused on the fact, oh, they're pregnant, you know. And also, I mean, leading on from that, there's also a reluctance to do normal testing on a pregnant woman, you know, because, oh heck, you know, can I put her in a CT scan? You know, can I do this, can I do that with her because she's pregnant? So this is why it's so important to raise awareness. And I think, you know, it's important that midwives, who are the first point of contact for women who are, you know, going to describe these symptoms, if the midwife just dismisses it, it's going to take a lot for that woman to tell anyone else about it.